Hi, this is Peter Blumenthal again, your steward and president, and it's my privilege to introduce Dr. Stephanie Simmons, a board-certified emergency physician. She is the Chief Medical Officer at the Dr. Lorna Breen Heroes Foundation. As you know, Dr. Breen was an emergency physician as well, and she was the primary advisor to NIOSH for the Impact Wellbeing Guide. I just Googled it. It's available on the internet. You can download it. It's a guide for healthcare leaders, and Dr. Simmons led multi-state programs to improve the operational environment of care and remove barriers to mental health care. She served as a national thought leader in healthcare workers' well-being. Dr. Simmons served as the Vice President of Patient and Clinical Experience for Envision over 7 years, serving 20,000 physicians and advanced practice providers with focus on professional well-being, including translational research and programs designed to bring well-being best practices to clinical environments. She served as lead clinical faculty for the Clinical Experience Project Wellbeing Program. She's been an advisor to us at the Medical Society. Dr. Simmons earned her Bachelor's of Science and Medical Doctor's degree from the University of Michigan and completed residency training at the University of Michigan St. Joseph's Mercy Emergency Medical Residency. She has completed additional training in medical education, research methods, coaching, and positive organizational psychology. Dr. Simmons, the floor is yours.
Thank you so much. It's a pleasure to be here with all of you. I'm going to share some slides and get started here. So I'm joining you today to talk about the work that's happening both nationally and in New Jersey around professional well-being for healthcare workers and representing the Dr. Lorna Breen Heroes Foundation in my role as Chief Medical Officer. As Dr. Blumenthal mentioned, Dr. Lorna Breen was an emergency medicine physician. She was the chief of emergency medicine at New York Presbyterian Hospital, where she practiced. And she was living the career and the life that she had always dreamed of, taking care of patients in Manhattan, living with her cat, and driving a fast car. She was actually on vacation with her family snowboarding when the first wave of the COVID-19 pandemic came to New York. And I think we all have very visceral memories of the sights and sounds of the spring of 2020. That is the environment that Lorna returned to. And she was taking care of patients. She was taking care of her team, trying to find PPE and protection and rational scheduling for them. And she ultimately, as many did, worked many 18-hour days in a row to do so. She contracted COVID in the first month or two that it was really active in New York. She became sick. She came back to work 24 hours after her fever broke, as so many did. But something wasn't the same. She was very fatigued. She was having trouble keeping up. And she eventually became so exhausted physically, mentally, and emotionally that she was unable to leave her apartment. She called her little sister in Virginia, where they were both raised, and a group of her friends, colleagues from residency, medical school, and work drove her back home. And she received inpatient mental health care, the first ever of her life, and she was discharged. After this, she expressed to her family that because she had received mental health care, she was worried that she was going to lose her state license to practice, her hospital credentialing, and her leadership position, damaging her ability to live out the mission that was all she had really ever wanted to do. And Lorna died. Lorna died by suicide. 12 hours after her death, there was an article about her life and her death in the New York Times that had been published over her family's objections. And what happened next was that first a few, and then a dozen, and then hundreds, and ultimately now thousands of healthcare workers, physicians, nurses, pharmacists, dentists, veterinarians have reached out to Lorna's family to let them know that Lorna is not alone, that there are many healthcare workers across the country who are concerned about the impact of mental health care on their professional prospects, that there are barriers to mental health care for healthcare workers, and that the environment of care is very difficult, both with regards to the human suffering witnessed, but also the unnecessary administrative burdens and harms that are experienced by healthcare workers. So the Dr. Lorna Breen Heroes Foundation was formed to honor Lorna, but also in response to the feedback of all of those other healthcare workers. And Lorna is not alone. So as Lorna's family likes to say, once you have lost a relative to suicide, you become part of a club that no one wants to belong to. And so other family members have reached out, the family members of Dr. Matt Gall, Dr. Scott Jolly, Dr. Lisa Lerner, Dr. Mo Brown, and a nurse named Tristan Smith, all of whom are physicians and nurses who have been lost to suicide, and whose families reached out to the foundation to share their stories and the lessons that they learned. There are over 22 million U.S. healthcare workers caring for the health of our country. And across the board, healthcare workers have worse mental health, higher levels of poor mental health days, of being harassed, higher levels of burnout, and desire to look for new types of employment than any other type of worker. When we think about why this might be, we look to the letter that nurse Tristan Smith left for her father after her death. And the letter is titled A Letter to My Abuser. And the abuser is not an intimate partner, but her employer. And she says, ever since I've young, I expressed my desire to become a nurse, but she no longer felt like she was being cared for as a healthcare worker the way that she deserved. And she went on to outline the environmental or the workplace problems that she was facing. And what we hear from the family members of healthcare workers who have died, and also healthcare workers who have experienced severe burnout or mental health conditions, is that their environment of work impacts their mental health and their ability to seek care. The American Hospital Association identified 3 primary drivers of suicide in the healthcare workforce: stigma, access, and job stressors. And with stigma here, we really think about 3 different types of stigma. So there's internal stigma, how we feel about ourselves when we seek mental health care; external stigma, how we talk to each other about mental health care; and institutional stigma, which are the policies and procedures in our workplace and in our licensing boards that increase stigma. And the American Medical Association has done a tremendous amount of work on the licensing and credentialing work with us that you'll hear about in just a moment. There is limited access at times to mental health care, either because of cost, availability, or cultural competence in healthcare itself, because the needs of healthcare workers and physicians are different than the needs of the average population in terms of their exposure to trauma and the types of situations that they're in. And when I think about job stressors, I think about those in really 2 categories. There's the stressors that are necessary, that we signed up for, being with our patients on the worst day of their lives, caring for them, witnessing their suffering, healing them. But there are also the job stressors that are viewed as unnecessary or not value added: the administrative burden, the work that's done in trying to get our patients access to care and get their care paid for, which is an additional burden that we're often underprepared for, and that can seem very unnecessary to the overall care that we want to give to our patients. In fact, when you ask physicians what are the causes of their symptoms of burnout, administrative burden, really is a theme throughout. So too many bureaucratic tasks, charting, paperwork, computerization of practice, government regulations sort of all roll up into that administrative burden category and certainly contribute to too many hours at work. We also see themes about respect and interpersonal relationships and change in control, locus of control or autonomy. So as a foundation, when we think about what is needed in terms of interventions, we think about these in terms of individual support and operational support systems. And these are different, right? So often the efforts and the resources around mental health access or burnout prevention have been around individual system support, access to mental health care, privacy in mental health care, peer support, education and training, confidential physician health programs. And these are all very important components of professional well-being, but they focus on building stronger canaries and not fixing the coal mine, right? So you need to do both. You want to protect the individual in front of you, but you also want to address the environment, which is what we see on the left side of this Venn diagram around operational system support. Rational workforce planning and development, financial resource planning, safety initiatives, quality improvement that takes into account the impact of the work on the and thriving. And all of this is facilitated by leadership training, governance, and communication between leaders, between physicians and their groups, between physicians and their employers, depending on the model. You know, I'm an ER doc, so the mental image I have here is of a patient in front of me who's wounded and bleeding. When you look at the statistics around burnout, that is a valid way to view our healthcare workforce. The first thing you need to do is hold pressure. That's the individual support. It doesn't fix the wound, but it helps the person in front of you maintain their if you don't go to the source of the wound, the source of the bleeding, and address that, then your patient could bleed to death. So as a foundation, we work in three ways. We work by accelerating the adoption of best practices and bridging the implementation gap between what we know works and what physicians are feeling on the ground in their workplace. We advocate for health workers, and we advance collaboration. And I'll talk about each of these and how we are doing this, including in New Jersey. So our collaborators nationally, we do this in two ways. The first way is through our All-In Wellbeing First for Healthcare Coalition. We have nearly 40 leading national organizations who have a stake in the professional well-being of the healthcare workforce. And you'll notice here the American Medical Association, the Nursing Association, the Hospital Association. But we also have, in addition to membership organizations, nonprofits like the American Foundation for Suicide Prevention. We have an EHR company, Epic. We have nursing associations, pharmacies. We have organizations that serve healthcare like Johnson & Johnson, FIGS, et cetera. And so the thing that all of these organizations have in common is that they have people within their organizations who are working on professional well-being for the workforce. So rather than all that work being siloed, we try to build an environment where they can come together, share their work, and connect with each other. We also have an ambassador program, and we now have about 485 ambassadors who are health workers, students, patients, family members, academics, healthcare leaders, and a group of family members who have lost a healthcare worker and their family to suicide. They engage with the foundation and protect and support healthcare workforce well-being through awareness building, through action at their institutions and their organizations, as well as helping us to connect with the organizations they belong to. So our ambassadors are all over the country and increasingly the world, including in New Jersey, and they are an essential part of the way that we do our work. I'm going to pivot and talk a bit about our programs and initiatives, including one that is going on in New Jersey right now. So Dr. Blumenthal mentioned the Impact Wellbeing Guide. This was work that was funded through the Dr. Lorna Breen Healthcare Provider Protection Act, which I will talk about near the end of this presentation. And it was designed to raise awareness about burnout in healthcare leaders and in healthcare workers. And in the initial work that we did in discovery, what we heard loud and clear from healthcare workers is we're very aware of burnout. Thank you very much. What we want is change. And what we heard from healthcare leaders is, yes, we've heard a lot about burnout. What we need to know is what to do about it. And so the Impact Wellbeing Guide is designed to be a starter kit for hospital and health system leaders on how to build a program around professional well-being if you don't already have one. It includes how to assess your current state, how to remove barriers to mental health care for your healthcare workforce, how to build bidirectional communication, build in professional well-being concepts into quality improvement projects, and how to build a strategic plan for your healthcare workforce well-being. It was guided by experts across our All-In coalition and really was shown to enable and empower healthcare leaders to implement practices and programs in our pilot of over 95 organizations. We did find, however, that although the guide is enough information to do this work, it really helps to have some consistent attention to the work within organizations. And so we developed a program called All In Caring for Caregivers that helps keep the attention on these programs as organizations work through them. And this started in Virginia in collaboration with the Medical Society of Virginia, Virginia Hospital Healthcare Association, Nursing Association, and the Virginia HIMSS. This is the Health Informaticists Group. It was funded by the Physician Foundation. We have next did this work in North Carolina, again in collaboration with the Medical Society, Hospital Association, Nursing Association, and a coalition group formed called the North Carolina Coalition for Physician Retention and Wellbeing. In New Jersey, we are working in collaboration with your Medical Society of New Jersey, as well as the Hospital Association, Nursing Association, and New Jersey Quality Institute. And in Wisconsin, we're working with the Wisconsin Hospital Association, Medical Society, and Nursing Association. We're also working with a locums employer who wanted to look at their own operational environment. So this is work that's done with philanthropic support in states in coalition with state membership organizations. In Virginia, we were able to change a licensing law that removed questions about mental health care from licensing applications for over 500,000 licensed healthcare workers across 62 professions, including the medical board, the medical licensing board. We were able to help 80% of the hospitals in the state remove questions about mental health care, diagnosis, or treatment from the credentialing applications and peer reference forms. And we had over 100 healthcare leaders engage in education around the systems approach to professional well-being. So that Venn diagram that I was talking about, how to impact operational changes as well as to provide individual resources. And these are the logos of our participants here. The third phase of the work after the licensing and credentialing work and the education was a learning collaborative so that organizations could implement best practices in their settings. And so we focused that around the electronic health record and optimizing the electronic health care record for health workers. And we did that. Different organizations focused on different types of health workers. So we had several organizations focused on physician documentation and reducing administrative burden for physicians. We had organizations such as Centra focus on nurse alert fatigue and reducing alert fatigue for nurses. And we also had organizations that focused on MAs. And what we're seeing is that nurses, physicians, MAs in those organizations noticed the work, felt seen, and cared for. And in this case, even impacted recruiting and retention. So the 7 systems that implemented quality improvement projects to address administrative burden showed measurable differences in documentation time, unnecessary alerts, improved satisfaction by physicians with the time spent documenting. And we did this with an approach that we call WellOps. Like anything in medicine, this is an acronym, okay? And I don't know about you, but I can still name my cranial nerves because of an acronym, and we're hoping that that would help people remember this as well. So WellOps stands for who's on the team, and with a focus on making sure that the people who are being impacted by the change are on the team. Examining your current state or really understanding what's happening now. Learning what's possible through case studies, best practice, and expert testimonies. Leaning into measurement and making sure that the measurement of the impact is actually important to healthcare workers. So I don't know about you, but a change in 1% of the clicks that I do for a process is not as meaningful to me as whether I get home 10 minutes earlier. And so we really wanted to make sure that the measurement was impactful to the clinicians. Operational planning, producing results, and then notably sharing what's working. And so the members of the Learning Collaborative shared with each other. And so they were able to implement each other's programs as well. So what we found is that through this all-in program, we're able to accelerate the pace of adoption of best practices, saving hours of documentation, getting people home, and as one physician put it, literally getting their life ahead of their documentation so that they could enjoy more time with their family. Another area that we work in is in mental health awareness for health workers. And this is the All-In for Mental Health campaign. Patients have the right to access mental health care and support. Healthcare workers have the right too. And in order to do this campaign, we really partnered with all of those All-In Coalition members and came up with 6 actions that states, employers, legislators, families, members, and healthcare workers can get behind. And these include accessible and affordable mental health care. And I would add here that this needs to be mental health care from people who understand what we deal with when we go to work. Because if I have a pediatric death in the ER and I want to talk to a counselor or a therapist about it, the tools and the techniques that they're going to teach me on how to deal that with, I have to go into work every day knowing that that could happen again in that shift. It's going to be different than somebody who may have experienced a single traumatic event and is unlikely to have to do that regularly. So we need culturally competent mental health care as well. We need physician health programs that provide an alternative to discipline when there's impairment and have a clear pathway for clinicians to return to work after impairment. We need to guarantee that peer support is confidential so that if you need to talk to somebody about litigation and your emotional responses to litigation, if you need to talk to somebody about a bad case you had and how you're feeling about it, that's protected and confidential. We need education across our career spans on mental health and professional well-being. And we need mental health care that is protected as private as our physical health care. So in licensing and credentialing applications, in peer reference forms, in payer credentialing applications, and in professional liability applications, we should not be asked about our history of a mental health diagnosis or treatment, just like we're not asked about a history of a physical health diagnosis and treatment. We're asked about our current ability to perform our work duties, but not our history of diagnosis and treatment. And so we developed this badge that you see here to recognize organizations that have made that change. In order to further define what the barriers are for accessing mental health care from healthcare workers, we partnered with the Heart of Safety Coalition and our All In coalition on a report on what clinicians perceive to be those barriers. And we surveyed physicians. We also surveyed PAs, NPs, and nurses because we were curious about how these are different among our colleagues. And what we found is by far external stigma in terms of state licensure applications, malpractice insurance, hospital credentialing, was a real barrier for physicians in receiving mental health care. They were also worried about their reputation with their peers more than any other group. So when you add together fear of judgment or stigma, self-judgment and expectations, and privacy or professional repercussions, again, that's internal stigma, external stigma, and institutional stigma. It added up to be the highest group. And it's interesting here, physicians are on the first bar here in brown. And there are some differences in every type of stigma. Physicians were more concerned about stigma than nurse practitioners, PAs, and RNs. And another thing that I thought was interesting with these data is that PAs sort of tracked along with physicians as opposed to with NPs. So there seems to be some differences in the medical model of training as opposed to the nursing model of training that we see around stigma. Of course, cost was less of a barrier for physicians because of the generalized higher socioeconomic standing, but availability and cost were still factors for many physicians. We also saw a large number of physicians believing that revealing a mental health diagnosis or treatment put their career at risk. And of course, this was Lorna's concern. So 60% of physicians believe that revealing a mental health diagnosis or treatment, their ability to get hired, privileged, or to practice would be in jeopardy. Or 43% believe that their professional license to practice would be in jeopardy. And so we start to see why questions on credentialing applications and licensing about mental health serves as a barrier to receiving mental health care because people are very concerned that their ability to practice their profession will be at risk. So at the foundation, along with our all-in partners, we developed the All-In Wellbeing First Champions Challenge for licensing and credentialing. And along with the AMA, the Federation of State Medical Boards, and the Federation of State PHPs, and physician researchers, we developed a best practice standard for language around mental health and substance use disorder on licensing, credentialing applications, peer reference forms. That includes a question about current impairment only, saying, for any reason, are you impaired from your duties as a physician or as a nurse or as a pharmacist or as a dentist? That allows licensing and credentialing bodies to fulfill their duty to protect the public and to make sure that licensees are not impaired without invasive and stigmatizing language around mental health care. Because as many of you know, because you filled out these applications over the course of your career, this is the yes/no section on the application, and it typically goes, have you been convicted of a felony? Yes, no. Have you been diagnosed or treated for a mental health condition or substance use disorder? Yes, no. And are you a pedophile? Yes, no. That sends a message to people filling out that application about how that organization feels about mental health care. And it's not always an intended message. In fact, it usually is not an intended message. But these questions are a remnant from a time where having a mental health condition or receiving mental health care was viewed as a moral failing, as opposed to a seeking of health care for what 1 in 5 human beings in our country will experience, which is mental health condition. So 1 in 5 people in the US will experience a mental health condition at some point, the most common ones being anxiety, depression, and substance use disorders. And physicians are no different. In fact, we have increased risk of some mental health conditions. So we are telling fully 20% of our physician workforce that if they seek care for their mental health condition, that they are required to report that. So we wanted to make a change to help encourage the change that had already started in the country. And so this is what that badge is designed to do. And currently we have badged states representing over 1.85 million licensed healthcare workers and over 350,000 credentialed healthcare workers. Anyone who has received this badge has met the criteria that is set forth in the AMA resolutions, and we are consistent with what that language is across all organizations. So any organization that has this badge has met that criteria. When we first started doing this work, there were 17 states where the medical licensing application was consistent with best practices. And that was largely because of the work of the Federation of State Medical Boards and the Federation of State PHPs and the AMA. Now, as of September, when we updated this map last, there are 40 states where the medical licensing application does not include intrusive mental health questions. I could tell you when we update this map next, Indiana has already been verified. Colorado has passed a law at the end of last year requiring the license to be changed. And New Mexico is in the process of making those changes. Your eye may have immediately gone to New Jersey because that's what everybody does when the map is up there and they're looking at their own state, right? And what I will say is we're pursuing 2 avenues of change for New Jersey, and I'm going to talk about that in a moment, but just know that although New Jersey has not made these changes yet, there are plans to do so. We are also tracking these pharmacy licensing and working with the boards of pharmacy across the country. And you will notice Idaho and Pennsylvania on all of these maps because they have made the change in every license that we track. Michigan will be joining them as a 4-license state as well. Nursing and dental licensing. And for a long time, there was only one state for dental licensing. It was Texas. And it was because of a single dental regulator who was an oromaxillofacial surgeon, also a physician, who championed this work in Texas. In addition to licensing applications, we are doing this work in credentialing. And as of September, there were over 1,800 medical centers, care facilities, hospitals that had verified both their credentialing application and their peer reference forms to be free of intrusive mental health questioning. We've also been able to badge 2 payer applications, several employers, and this month we badged our first 2 professional liability insurers. That's Curie and Empro. And we are in the process of working with a number of additional professional liability insurers as well. There are several hospitals and health systems within the state of New Jersey who are in the process of receiving or of doing this work to receive the badge. So I promised you that I would tell you about the work underway in New Jersey to get the medical licensing changed. We have been working with the New Jersey Division of Consumer Affairs, and we have met philosophical agreement on the need for changes in the current language. And they will be working with the MedExec Board, Board of Nursing, Board of Pharmacy to make changes, hopefully in Q4 of 2025 and Q1 of 2026. So it is our hope that the next time we update this map, that New Jersey is on the map for medicine, nursing, and pharmacy. We have also been working to introduce bills in the New Jersey legislature with the guidance of the Medical Society of New Jersey and advocacy from the Hospital Association, Nursing Association, working together, introduced two bills, A5594 with Assemblywoman Donlin and Senate Bill S4286 by Senators Gopal and Vital. And so, it is our hope that these will be passed either by the end of this year or introduced early in 2026 with rapid passage, which would codify into law the changes that are already underway with the New Jersey Division of Consumer Affairs. If you are working within a hospital or a health system or medical group, you have the opportunity to engage in this work as a credentialing champion and leading this work in your organization. And so I encourage you, we do have a toolkit for organizations on how to get this work done for credentialing of hospitals, health systems, and medical groups. I encourage you to download the toolkit and lead the work in your own organizations. Time and time again, we have seen that one champion within an organization is what it takes to get this work done. One person raising their hand and saying, I want my organization to be consistent with nationally recognized best practices around this issue. I want my colleagues to feel comfortable seeking mental health care. And I want to make sure that my organization is doing everything they can to support that. And so we've even had one organization, Albany Med in New York, where a medical student came back from a conference having heard about this work and along with their faculty mentor, led this work in their organization. So I encourage you as physicians and physician leaders to download the toolkit and champion this work at your organizations. In addition to advocacy at the organizational level, we're doing advocacy at the national level as well. And one of the ways we do that is by keeping the issue of the healthcare workforce well-being in the lay press, because legislators, family members, decision makers are often reading lay press as opposed to journal articles where we do a lot of the academic publishing, right? And so we want to make sure that the data are out there in the lay press and that people are aware of that. So we do a lot of lay press publishing as well as some academic publishing. We also do advocacy at the federal level. So one of the things that happened after Lorna's death was that the Virginia senator, Senator Tim Kaine, called Lorna's family to express his condolences of her death. And he and Lorna's brother-in-law, Corey Feist, started talking about healthcare. Corey was at the time the CEO of the University of Virginia Medical Group, working for the physicians there. And Senator Kaine said, my son is in the military and there's a lot of mental health resources for them there. Surely there's something like that for healthcare workers. And the conversation sort of went respectfully, sir, there's not. And so out of that conversation and the dedication of Senators Kaine and Senator Young from Indiana, championing this issue in a bipartisan, bicameral way, the Dr. Lorna Breen Healthcare Provider Protection Act was passed, which was first of its kind legislation funding professional well-being programs across organizations and establishing the Impact Wellbeing Campaign. So this was signed into law on March 18th, 2022, and expired in 2025. And we're currently advocating for the reauthorization of this law with an emphasis on reducing administrative burden. As you can see, it's President Biden signing this bill into law. If you look behind President Biden, you'll see Jennifer and Corey Feist, Lorna's little sister and her brother-in-law, the co-founders of this foundation, as well as Lorna's niece, Charlotte, and her mother, Rosemary, who was a psychiatric nurse for 34 years. So it was, very powerful for the family to be there and to see this bill signed into law. As I said, we're working on reauthorization right now. We were in the 2024 year-end package and hoping to be passing the bill in 2025. The reauthorization would extend the law for another 5 years, ensuring support for the programs through 2030. And the reauthorization focuses on reducing administrative burden. But even after reauthorization, we would need to find funding annually to secure the financial resources. So this QR code leads you to an advocacy action. If you go there, you can put in your zip code and it will let you send a note to your representative. And what I always tell people is add a sentence or two about why this is important to you, because that storytelling is really important to our representatives to hear the why behind the what. And I always say, as a latecomer to advocacy, that it's really about the heart and the head, and then a path forward to a solution. So as I've talked today, I've talked to you about how our foundation was started, the work that we're doing, and I want to leave you with a few ways to act. So first, you can lead your organization to becoming a credentialing champion through downloading the toolkit and working within your organization to advocate for removing invasive questions about mental health care from your credentialing applications and peer reference forms. That's the QR code on the left. You can work within your state to advocate for the passage of New Jersey Bill A5594 and SB 4286 to remove stigmatizing language from licensing for licensed healthcare workers. And you can write your representative for passage of the reauthorization of the Dr. Lorna Breen Healthcare Provider Protection Act. So I hope that you will take a moment this evening to consider one of these actions and to think about how you want to engage around this issue. So I am happy to answer any questions. I also want to mention that in the US, we are fortunate to have 988, which is 911 for mental health. So at the end of every talk that we give at the foundation, we remind people about this lifeline. There's a text line at 988lifeline.org and also a emergency response phone number at 988 dialed on a phone to access emergency mental health. And one time we had somebody raise their hand and say, I heard you talk before, heard you talk about 988 and I didn't know it, but the person in the audience who was going to need that number was me. And they were able to use it to help a colleague within the next week. So I want to leave you with that thought and also happy to answer any questions that you might have.
Yeah, I actually have a question. Dr. Simmons, thank you for this amazing presentation. I'm curious to hear, having worked with you for some time now to advance the legislation that's pending in the Senate and the Assembly, I'm curious to hear your thoughts on the biggest challenges that you face. You know, this is inspirational legislation. I think you and I have both said in the past that this is low-hanging fruit. It's the kind of thing that essentially no one opposes. It's almost impossible to oppose, honestly. But I'm curious, you know, there's an old adage, I was a state government lawyer for many years. There was an old adage when we had a new policy that we wanted to push out, that culture eats policy for breakfast, or lunch, I guess, if you're in the office. are there challenges that you're finding, such as cultural norms that are just really hard to change, no matter how much legislation we pass?
So the biggest challenge to any of this work is competing priorities. I don't need to tell anybody on this call that working in healthcare is busy, that there's a lot going on. Our individual careers, our organizations that we work for, and even our advocacy organizations and our membership organizations have a lot that they're trying to accomplish and do. And keeping this issue at the forefront is truly the biggest barrier to the work moving forward. In terms of the stigma, it was interesting in that Heart of Safety Coalition report that I was referencing about perceived barriers to mental health care. One of the questions we asked was, if you learned that your colleague had received mental health care, how would you feel about them, their ability to provide safe and competent care? And for physicians, 90% of physicians, overwhelming majority, were neutral or felt positive about their colleagues' ability to provide care. But 1 in 10 said that they would doubt their colleagues' ability to provide safe care if they received mental health care. Any mental health care. We didn't even mention anything about impairment. And I think that that's really important for us as physicians to recognize that our colleagues who receive mental health care and are worried about disclosing it, that concern, that stigma isn't coming from nowhere. And it really, if you have that 1 in 10 person is the person responsible for hiring you or for promoting you, right? Or for making sure you have an opportunity within the hospital, there is a real potential career risk. So here's my charge to all of you. If you are that 1 in 10 person, consider the fact that you are putting your colleagues at risk and your patients at risk by creating an atmosphere where 20% of your colleagues who may need mental health care in their lifetimes are less likely to receive it. Examine why you think someone with a mental health condition may not be competent to be a physician, and listen to the stories of physicians with mental health conditions who share their own experiences. If you're one of the 90% of people who's neutral to positive, especially if you're one of the 40% of people who's positive, declare yourself. Share who you are and why you feel that way, because your colleagues need to know that you're out there. And we can't let 10% of the people dictate 100% of the policy. So there is a minority position that currently is driving our policy. And what I would say is our supportive colleagues need to be verbal and supportive, and that's how change is going to happen. Yeah, ask me a question, you get a sermon. Sorry, Josh.
Great answer. I appreciate it.
All right. You guys only get 17 questions, so not everybody all at once.
No, if I may, I have 3 thoughts to offer. I've been heard to say first that some people are doctors, but all doctors are people. And second, seeking help above all shows strength. And third, this is a private comment not endorsed by the Medical Society. We happen to have an excellent professional assistance program in Princeton, headed by Dr. Lou Baxter, former president of the American Society of Addiction Medicine. Please hold on to these 3 thoughts.
Thank you, Dr. Blumenthal. Every single one of us knows a colleague, one of our respected and cherished colleagues who has a mental health condition or a substance use disorder. And if you don't know somebody, it's because you don't know you know them. They are there. And we need to make sure that we are caring for our colleagues and protecting our profession, and our professional ability to provide excellent care to the best of our abilities. So I thank all of you for your time and your attention, for joining us at the Dr. Lorna Breen Heroes Foundation in this mission, and especially thank the Medical Society of New Jersey for their partnership in this work.
Before you go, I have a question. Hi.
Hi.
I'm Shirley Thompson. I do credentialing and privileging at my hospital. So I'm very interested in how to change those questions on the application. Does the Medical Society of New Jersey have a sample that we could begin to look at and begin to look at what we do on our applications?
So I don't have a sample, but something tells me that Dr. Simmons and her team do and would be happy to work with you.
Yeah. So Shirley, on the screen right now, on the left-hand side, there's a QR code that says Credentialing Champion Challenge.
Sure.
If you follow that QR code, it leads you to a toolkit that is a toolkit of best practice language around credentialing applications and peer reference forms. And we have examples of language that is stigmatizing and what it can be changed to. The National Association of Med Staff Services has ideal credentialing standards from 2024 that are consistent with these best practices as well. And we will be thrilled to badge your organization and provide you with a communication toolkit once your applications are there.
Perfect. Thank you so much. I appreciate that.
You're very welcome. And also, I'll put my email back up here again. If you have any trouble as you're accessing those resources, please feel free to reach out to me directly.
Thank you.
Thank you, Dr. Simmons. That was a good presentation. It was helpful.
It's my pleasure. Thank you all. And I hope you have a great evening.